Hi, this is Dr. Kathy Vierhusen, and I'm going to be going over what we have covered this week, which is week 10 in Nursing 340 Community Wellness Theory. And I'm going to start the slideshow. So I'll share my screen with you. And I'll get this up to where it's a slideshow. Okay, there we go. So this week we're continuing our discussion on care of populations affected by disaster. Last week we looked at a lot of natural disasters. This week we are going to look at how do we respond to those disasters. Before we were talking about how do we plan for them. Now we're going to talk about how we respond to them. So one thing that I want you to keep in mind as you're looking through this material this week and viewing some of the videos is that we really do have a reason to the things that we're doing. And it can seem pretty cruel when we're going through and doing our assessments at disaster compared to if we were doing an assessment in the emergency room. We've talked before a lot about patient needs exceed the available resources, and in a disaster that is particularly important. And we really want to do the greatest good for the greatest number of people. And what that means is sometimes we are going to bypass someone that under normal circumstances, we might have done heroic efforts to save, but we want to save the greatest number of people. We'll talk a little bit more about that. So we have different stages. We have the primary stage, which is where we assess and then transport rapidly to for those patients to get further care, more intense care than we can receive or give them on site. And then the secondary is that we would then hold and treat at the scene those that we can treat at the scene. It's different than emergency department triage, where it's determining what is the best care for this patient. We're determining the entire group, and some of those who are injured will be assessed as non-viable. We'll talk a little bit more about that. Okay, so this week I did ask you to view a response to the great earthquake in Japan and how the Federation of Red Cross Hospital responded to that. I thought it was a very interesting video when you look at how they staged things and how coordinated they were. They obviously didn't do this without practice. And so that's the reason when you get into the acute care setting, particularly if you work in ICU, or in ER, you are going to be part of a disaster drill. So it is going to be, how do we receive a lot of patients to our hospital if we have just undergone a disaster in the area? And whether or not that's a plane crash or an earthquake or a tsunami or something else, but how do we receive, how do we triage, how do we receive those within the acute care setting? So on the upper right-hand picture in this slide, you will see a picture from that Red Cross, Federation of Red Cross response team. And you saw that play out, or will see that played out in the video. On the bottom left, we actually have a similar response. It's one that was in response to an earthquake that actually happened in Haiti. And so how did they respond there? And in the upper left-hand corner, you see two nurses that are part of the overall planning, and they are being very systematic in what they're going through and the roles that they have for everyone. So this is what we do in the acute care setting when we're expecting a lot of patients to come in at once. But I want you to think about a question right now. Which situation shows the highest likelihood that a bystander will intervene in an emergency? So here's our two options. A large group gathering where many individuals are available to perform different functions. Or B, a small group gathering where a limited number of individuals are available to assist. Think about that. Which do you think that you would be involved in? The answer is the highest likelihood of having a bystander intervene is actually B, a smaller group gathering where limited numbers of individuals are able to assist. I'll give you an example. When I worked in the free care clinic and did childbirth education classes, we also did CPR for infant and children, which included first aid and the Heimlich maneuver for the people that were going through the childbirth education class. We covered the Heimlich maneuver on children and infants. I received a call about 3 weeks after one of our sessions where a mother was relating to us through tears, through much of the conversation, that what she had learned in the class had become immediately necessary for her young 5-year-old autistic child. She was at a family gathering over Christmas. There were probably 20 people there, so a small gathering, really. It wasn't like there were hundreds of people at an outdoor concert. This was a small indoor gathering. There was a buffet table that had quite a few foods on it. The children were playing as usual. And her 5-year-old had, like the other children, would play and then come and partake in some food and then go and play again. And what she had noticed was he was really enjoying dips and chips. And so she was fine with that. She did look over at one point, though, and realized that he had stopped playing and was looking like he was in distress. She assessed very quickly in her mind that she thought he was choking because she had seen him shovel dips and chips into her mouth. And so she thought that he was choking. She went over to assess it. She said, but actually, in my mind, she was thinking, I wonder if somebody else here knows what to do. And she quickly looked around. She looked at her in-laws, she looked at her own parents, and she looked at the others at the gathering and realized quickly no one else knew what to do. And she thought to herself, I know what to do. I'd better intervene. Now, this is her own child. She was right there, but she was hoping that somebody else would know. It was just common instinct that she wanted somebody else to be able to do this. She followed the directions that she learned in CPR and was able to clear his airway relatively quickly. It sounds like from what she described, but it seemed like eons to her, as it would to any mother who was having a child who was choking. She was able to clear his airway. He did fine. He did not need any transportation to the emergency room. She let him sit quietly for a while. He kept saying he was fine, he was fine, he was fine. And that usually is what happens when somebody chokes. They're fine after you clear their airway. But it was in that situation that she realized that if there had been hundreds of people, she might have delayed a little bit longer because she would have been seeking somebody else to do it. Bystander interventions are key to large disaster situations where people are injured, and they can indeed create a positive outcome for what went on. Let's look at a couple of examples. So I'm going to read this to you because I think it's very important that you hear it and read it. So this happens to be from an article called Bystander Intervention Prior to the Arrival of Emergency Medical Services, Comparing Assistance Across Types of Medical Emergencies, from a journal, a peer-reviewed journal called Pre-Hospital Emergency Care. Experiences throughout the world with mass casualty events and other life-threatening emergencies have highlighted the important role of bystanders. Bystanders are a person at the scene of an event who voluntarily step forward to help, and their early assistance may reduce morbidity and mortality. Because bystanders usually outnumber professional rescuers, their involvement may strengthen response to emergency events. Vivid examples of bystander intervention during emergencies are available. After the explosion during the Boston Marathon in 2013, a high survival rate was noted, in part due to the response of bystanders and first responders. In a report of 619 survivors of the Haiti earthquake, it was found that 71% of the injured reported that a friend, family, or neighbor had pulled them from the rubble, and that less than 1% were rescued by professional rescue services. Another act caught on video shows a group of 10 bystanders in Utah lifting up a 4,000-pound automobile to rescue a motorcyclist who was pinned under a burning car. So indeed, bystanders can make a difference. Here is a very vivid example of that. This was the Las Vegas shooting in Nevada. If you remember, in 2017, there was a shooter, a sniper actually, that housed himself in the hotel of Mandalay Bay. He had direct visualization of those attending a festival concert below, and he opened fire, and he killed 59 people. The majority of the people who died of massive hemorrhaging. And if you don't think it's going to happen around here, which most people don't, most people say, I never thought it would happen here. I'll relate. In 2019, we had a mass shooting event in Madison. It was actually Middleton. And it was, you see the armed intruder there. He came into the Paradigm company, and he injured 4, and he was shot within moments after opening fire, and that was due to the wonderful response of first responders on knowing what to do as far as clearing the building, bystanders and individuals themselves, and then actually law enforcement on how well they were drilled for this. What was interesting in this one is that they had some drills in the company about what would happen if somebody came into the company with a gun. Not that it was a high risk, not any more high risk than any other company, but they had done that. You will see that. You go through that in your own place of business once you get out in the working world, if you haven't already. Okay, so there's a couple of different algorithms out there, and the reason I'm going to show you two examples is because I don't want you just focusing on one example and saying, oh my gosh, you know, we learned this one example, this is the way it's supposed to be. There are different roles for that. You're going to find out what you're going to do within your area. The SALT one is one that's kind of, I think it's a little bit out of date now, but you may still see it out there. SALT stands for, you're going to sort those people that you have in your area, you're going to assess them, you're going to do life-saving interventions if you need to, and you're going to treat and transport those that need to go. And you'll see the algorithm here, and I think have it posted on one of these weeks within Blackboard. So you can see that it's a typical algorithm. You say, if this, which way do we go? The reason I think this one is a little bit more outdated is because I see the next one more often. And the next one talks about not doing life-saving interventions. So we'll talk a little bit about that. Here's the one I see more often, the start triage. And basically it is, if you move, you're going to go systematically from person to person to person. And if you come across someone who has no spontaneous respirations, and you adjust their airway, just like you learned in CPR, you adjust their airway and you still don't see any spontaneous respirations, you are going to tag them as non-viable and you're going to move on. It seems very cruel because I understand that heroic efforts could probably save this individual. But while you're performing heroic interventions on this first person who has no spontaneous respirations, you may be avoiding giving care to people that are much more viable, that just need to have perhaps bleeding stop, or they need to be able to be transported and taken care of. You may have people that have vital signs and they're starting to turn for the worst. If we can get them transported, they are much more viable than someone who has no spontaneous respirations. So this one talks about, I'll go to the next slide because it's a little bit easier to understand than this one, but you're going to use black, red, yellow, or green tags as you systematically go through and look at your individuals and assess them very quickly to cover as many people as you can. So basically you're going to say, when we talk about all walking wounded, basically what I'm going to say is that if I walk into the situation is I'm going to say, anybody who can hear my voice and respond to my commands, please wave your hand. I'm going to see all those people that wave, right? And then I'm going to say, if you're able to walk, if you're mobile and able to come to me, come over towards me. Then I know I've got my walking wounded. They may be wounded. Probably if they're not wounded, they're probably not waiting for my commands. They're probably milling about trying to help people. But if they're walking wounded, I'm going to get them into one section. I'm going to say, I'm going to just quickly go through them and say, you were able to walk. There doesn't seem to be anything majorly wrong with you as far as your life that's life-threatening. We're going to have you here and we're going to wait to transport you. You can please take care of each other. Then I'm going to start moving on. So I'm going to move on. I'm going to say, do they have any spontaneous respirations like I talked about before? If they don't, I'm going to reposition their airway once. If they still don't have spontaneous respirations, I'm going to tag them as black. That is non-viable individual. I'm going to move on. Let's say I get to the next person. They do have respirations. Okay, great. They have respirations and they are under 30 respirations a minute, which means they aren't hyperventilating. They are not breathing rapidly because they don't have enough oxygen in their system. That is just something we do. We breathe rapidly when we're having problems. So under 30 a minute, and they're perfusing. They've got a radial pulse, or they have a capillary refill that is less than 2 seconds, okay? So if they are breathing under 30 minutes, they're perfusing. If they are, they're breathing. If they have perfusion that is good, then we're going to put them as a yellow. That's going to be delay. They can follow, especially if they can follow simple commands. You can follow that algorithm down there to delay. If their respirations are over 30 a minute, we are going to tag them as red, as we would with someone who did not have spontaneous respirations, and then we moved their airway and they regained their respirations. We're going to tag them as red also. Red means we're going to immediately transport them. The first ambulances that start arriving, these are the people that I'm saying this one and that one need to go right away, according to the algorithm. Also, if they are breathing and they have a radial pulse present, but they cannot follow your commands, they might have a head injury that needs immediate assistance. We're going to tag them as red. Or they are breathing. Their radial pulse is absent, or they have a greater than 2-second capillary refill. We're going to have them as immediate. They are probably bleeding somewhere. Okay, so you're going to see this play out. If you haven't done the virtual simulation already, you'll see this play out. The students really enjoy this virtual simulation where it's a truck and a train, a bus and a train accident. Something that we've done as a healthcare entity, as our profession, is we have started this layperson's education on Stop the Bleed. And it's see something, do something, right? So you see somebody bleeding there, you're going to need to stop the bleed. The reason that we put this in, and you actually have a short video that is the actual training on this. The reason we put this in is we found that nursing students who were doing the disaster training in person were having a hard time with, what do I do with a bleeding person? Somebody's lost an arm and they're bleeding. You're going to have to get some way in order to control that bleeding, or they're going to bleed out very, very quickly. So it talks about you're either going to have the victim themselves apply pressure if they're able to do that and they're not getting dizzy or that type of thing. That's that first picture. The second one, you might pack something, a scarf, a t-shirt, somebody's sweater. You're going to pack something in that wound. You're not going to worry about infection right now because we can give them antibiotics when they get to the hospital. You're worried about the fact that they're going to die from hemorrhaging before they get to the hospital if you don't do something about the bleeding. So you can pack that and then apply pressure. You want to apply pressure until the bleeding stops or until you can no longer physically do it. And if it is on an extremity and you have the ability to have a tourniquet of some type, whether it's a real tourniquet that's made for the situation or whether it is a belt or whether it is a scarf or whatever, you're going to do that until it stops the bleeding. Don't be fooled. This is going to be very uncomfortable by the people that you're doing it for. This is not the time they're going to say, thank you for saving my life. They're going to be like, what are you doing? And you're going to be like, I'm doing this to save your life. And this is what we need to do. So stopping the bleeding is really important. And that's the reason that I have you watch that video. Here's another poster that comes from Stop the Bleeding. It talks about applying pressure with hands, applying dressing and press. And it's not just a superficial dressing that you're just going to continue to change it as it gets, more and more wet with blood, because that's blood that this person is losing. Or you're going to apply a tourniquet. And it did have some pretty good illustrations of some of the professional tourniquets. Some places next to the defibrillator on the wall will be a Stop the Bleed kit. I think we'll see those more and more as time goes on. Okay, that's it for this week. It's not a long lecture because I gave people time in order to do their simulations. And so you're going to do simulation number 3, I think it is. Don't quote me on that. It's in Blackboard, but it is the train versus a bus accident. And you're going to have a field of people that need you to assess them, and you're going to go through and tag those people. Okay, all right. As usual, you let me know if you have any questions and contact me if you have any. Okay, thanks.